Now, one of the wrinkles, one of the challenges in interpreting this is just that this is a global trial and not every place had access to Tagrisso as their preferred treatment when people came off the study because of relapse. In the US and most of Europe, it is readily used. And so essentially the ideal way we would hope to see the results is one arm giving everyone Tagrisso at the beginning proactively after surgery, and then the folks who have relapsed getting it just if they need it, when they need it later. What we saw is kind of a mishmash of different treatments after the patients on the placebo arm developed relapse, and that most patients, 88%, got an EGFR inhibitor. We certainly want that, but only 43% of the patients who got a treatment got Tagrisso, osimertinib. That's under 40% of the patients who had a relapse at all. And we know that EGFR inhibitors, clearly provide a benefit, but osimertinib is really the leader in this setting. It has the best overall activity and particularly protects the brain, which we really consider to be an important aspect. So the question, I think the main question about this is, if a lot of the patients didn't cross over, how much does that challenge our understanding of how much the benefit would be? I would say that there's very little doubt, at least in my mind, that this leads to a significant improvement in overall survival, even if there were much better, almost perfect progression or transition to crossover to Tagrisso. It would be less than what we see here, but it doesn't change the conclusion that not only is there a huge benefit in disease-free survival, but an improvement in overall survival. And so in that sense, it is what we might term practice affirming for the places that have been doing this since 2020 based on the huge DFS benefit. But I think there's room to reflect on this. And Alfredo, I know that you've had some concerns about the crossover. What's your take home on this, and whether that overall survival benefit is quite substantial or diminished by this crossover question?
Yeah, thank you, Jack. That's a great question. It's $1 million question, and I don't have the clear answer. So just to be perfectly honest, I totally agree with what you said. This is a positive study. It was positive from the beginning. This is for survival. Now we have the secondary endpoint. So there is overall survival benefit. And I don't know is the answer. So I don't think anybody can really say that, we can see that 12% of the patient who relapse never get exposed to any TKI. How important is that? Is that? I don't know. It might have an impact. So I cannot say that the overall survival will be still positive, but less positive, or it would not be positive. And we need it at the end of the day. I think we need to accept the study that's been run. This is a positive one, and I think has changed practice and will keep reinforcing this. So I guess that what is important for the people that are going to watch this, it's important to discuss with your oncologist pros and cons, because the other point that we need to highlight is the toxicity. And at least I'm sharing my experience that I'm quite sure it came up in the paper. So osimertinib with Tagrisso, it's quite, we all agree it's quite a manageable drug, particularly in a metastatic setting. But we know that the toxicity, which is pretty much the same even in the adjuvant, the threshold for tolerance, it's lower. So we've seen a good number of patients asking to stop the drug, and it was reported in the paper. So it's not life-threatening toxicity, but if I were a patient and having paronychia, for instance, it might not be a life-threatening side effects, but it's a side effects that touch your nails and you might struggle to walk. So it might sound something, really a bit silly, but it could be a problem. It could really let people to say, oh, I had enough, I cannot stay 3 years on this drug. So it's a positive study that if I offer this drug to a patient, I would discuss pros and cons. And I think it's reasonable even without OS, to be honest, discuss the disease-free survival, because I think it very much depends where you are with your life. And maybe you want to make sure that for the next 3 to 4 to 5 years, you want to increase your chance to be free from this cancer, because for whatever reason you have things to do, and children like me growing up. So it makes sense. But claiming for sure that the overall survival would be positive anyway, even if we had done a perfect study, I think it's an overstatement.
One thing I need to clarify, I made a mistake on the slide. It's the 43% of patients who got treated. It's 38.5% of the patients who had relapse. This number here should be 79 patients representing 38.5. So just a little error. But let me turn to you, Christine. This was a plenary session. It was very well received. I don't know if you feel the crossover was kind of an overstated concern or a legitimate concern. And, it's just always a question when we have trials that are run globally that have different local standards of care.
Yeah, thank you. So I'm going to zoom out for a second and say, I think there's probably a broad range of people listening to this discussion, and some people have probably thought about this topic a lot, and some people who may just be engaging the world of lung cancer and EGFR mutant lung cancer. So just to frame this is the first targeted therapy that's approved in the post-operative setting. So that's huge news in and of itself. In other cancers like breast cancer, there have been targeted therapies after surgery for years. So this story makes a big splash in lung cancer because it's the first time we're really using a targeted therapy option, and targeted therapy where you test a tumor for a specific mutation or for a specific change in the blueprint of the tumor, and then use a drug that matches that change to actually affect the outcome from the tumor therapy. And so to me, that's it's paradigm shifting in terms of how we treat lung cancer, and that's big news. And so I think that's really setting the stage for this trial, and to me that's an important take-home message. To be very honest, this trial was more positive than I was expecting it to be. And when I say positive, the metrics we use as doctors and trialists, these HR hazard ratios that you see as a flash across the slides, it was better than I thought. I didn't think that the result was going to be quite so good. And we can flesh out all the nuances. I think Jack expresses some real concerns. There is no such thing as a perfect trial. There never will be. The concerns are real. But I think, for the purposes of this audience, what I would like to convey from my perspective is I'm enthusiastic about this trial because it offers a targeted therapy option in the adjuvant setting or the post-operative setting. I think it was, to be honest, from my opinion, the results are better than I was expecting it to be, both for disease-free survival and overall survival. Two different metrics of how we assess response. Was the design perfect? No, and I think Jack makes some very good points, and that are, we have to think about critically in terms of how we think about the magnitude of the benefit. So it's important to think about that contextually. And also, I think something we haven't discussed amongst this group is this trial included patients of different stages. There was, stage 1B, stage 2, and stage 3, and the magnitude of benefit for the drug was greater for patients with the higher stages, which makes sense. And so, when I talk to my patients about this study, I also put it into framework, not just the overall study, but how the overall study fits in with the specific stage disease that the patient that I'm meeting with has. And then Alfredo's point about, I think every individual's, not just their disease, but we treat patients as a whole and their entire life context. And so these discussions are very nuanced as we have them with our patients in clinic. So overall, I'm enthusiastic about this because I think it's paradigm shifting in lung cancer. There are some legitimate concerns about this study. It's really a discussion that you need to have with your physicians. I do use this in the post-operative setting, and I'm eager to see how this paradigm is now going to shift to potentially other oncogenes, other markers in the post-surgical setting as well.
I think that's a great point. And I would just underscore that even though I have been critical of some of the trial design issues. It's largely just from the standpoint of hoping to do as well as possible by the people who haven't had access. I don't want to perpetuate disparities, but that isn't meant to take away from what this means. And I would say at the end of the day, I favored guiding treatment based on the huge disease-free survival benefit we saw 3 years ago. And I would do the same now. You know, I think it is still practice reaffirming, even with the concerns. I just think that we should continue to struggle to deal with these disparities and run the best trials we can. But
100%, Jack, I think kudos to you. I mean, I think what I take away is you're advocating for those patients who don't have access to the drug or can't get the drug, so that they have it, and that's wonderful. And
I think we're at the, you know, we're really having these questions because we know it's such a good drug that we just want to make sure everyone gets it at some point, earlier, probably better. So